Hello, everyone. Welcome to another episode of the 260. We have Dr. Scott here again. And Dr. Scott, you went to a conference here in California. And
Yes.
I just want to pick your brain. What was some research that you just kind of pulled from that conference that you're thinking about, that's interesting, that might affect us here in Fort Wayne, Indiana?
Sure, absolutely. Yeah, it was the National Association of EMS Physicians Conference. It's the largest one of its kind, actually in the world. There's about 1,600 medical directors from the United States and Europe that attend that, and it's very interesting. A lot of presentations, research presentations, and studies, and what major EMS systems are doing. And it's really interesting to see what's going on in Europe. Like places like Singapore and how they manage EMS as a country versus how we manage it here, in terms of cities and fire districts and townships, and many places take it on very differently.
Yeah.
As a national resource, and so. But a couple of really interesting topics. One, there's a lot of discussion about wellness.
Yeah.
Right, and keeping your providers healthy, wellness, recruitment, retention. The National Registry did a huge study on retention in the workforce, and what model was retaining EMS personnel the most, and really the fire-based model, the professional fire-based model in particular, as here at Fort Wayne Fire Department, is considered to be one of the best in terms of longevity for career and folks that enter that and stay in that workforce. And so many other systems are trying to look at, why is that? How can we retain our EMS providers? For instance, here, like at Trawl, what is it that fire-based systems do? And a lot of it has to do with, pay and retirement and working conditions, and a lot of things that some systems just can't. They just don't have the financial ability to do that. But I was happy to see that there was a lot of presentations about recruitment, retention, and wellness of the providers.
Yeah.
So that was really good, I thought.
What were some things like specifically on the wellness of the provider that you thought was like interesting? Was there anything about like the 24-hour systems, like on sleep or anything like that?
Yeah, there was some. There's always a discussion about circadian rhythm, sleeping, and all that. Is a 24-hour shift the right thing to do for an EMS provider? Should you be doing shorter shifts? And some fire departments do have shorter EMS shifts than the fire suppression shifts, as an example, just because they're doing more, they're making more calls, they're doing a lot more activity. The other thing is, they talked a lot about, critical incident stress debriefing. How do you do that?
Yeah.
Who does that? When is it done? When's the best time? How do you handle people that have, really bad pediatric calls? What do you do with those crews? Really a lot of interesting work around that.
Yeah.
In keeping, your providers sane after seeing, the horrific things that you see, right? Because you do see terrible things.
I don't think any of us are really that sane if we're in this career.
Well, maybe
but
not.
yeah, but yeah, we don't
Sanity
want to
perhaps
be
is not
like
a requirement, but
like we don't want to be too crazy. We want people to think that at least know what we're doing.
right.
Yeah.
So so it's good to see a lot of work being done with that.
Yeah.
The whole thing about, taking care of the providers. You got to take care of the providers in order for them to be able to take care of their patients.
Yeah, and it makes workplace a way better spot.
Yeah,
Like if you're not saying that your boss has to 100% care about you, but if they at least give a little bit of cares.
Absolutely. But what they found most is it's peers, right?
Yeah.
It's your peers and peer support groups, and
Yeah.
that really probably provide the most support in terms of wellness.
Yeah.
So there's some organizations that have, peer support groups and peer, stress debriefing groups and stuff like that.
Yeah. So what are some other things you noticed at this conference?
A couple of things. The double sequential external defibrillation is it's been, again, particularly with refractory ventricular fibrillation, has been shown to be probably the right thing to do. There's been some multi-city trials, and there's been some multi-country trials. There's some trials that were done in Europe as well. And so we're actually looking at changing that in terms of in refractory VFib after the third shock. Right, already in the protocol, you should do a vector change, which means,
Mhm.
if you tried 3 times, well, try something else, right? And
Yeah.
change your pads around, see if you can get, anterior, posterior, as an example, has probably less impedance in terms of passage of an electrical shock than the right upper chest and the left lower chest. But the question is, should you add another defibrillator?
Yeah.
And again, those are not firing at exactly the same time. They're firing sequentially.
Yeah.
There was some concern that you would, fry defibrillators, and there has never been any reports of that happening. But the concept is, shock, right? Not,
Yeah.
not
And then
shock
you
at the same time.
and you have one person, 2 defibrillators side by side, that way you know they're not shocking at the same time, and it's like push,
Right.
push.
Right. Right.
Yeah.
Yeah. So in many cardiac arrest cases, we'll probably be asking that there'll be 2 defibrillators on the scene.
Yeah, which for
In
our
the cities,
system,
yeah, well,
yeah,
yeah, right. You'll have that.
yeah,
You'll have that. So that's something we'll probably make in a pretty immediate change to do that. We talked, I think, in one of the earlier podcasts about should you be doing CPR in pseudo PEA trauma arrests, and the answer to that is probably no. But the
really.
real question is, how do you know it's a pseudo PEA?
Yeah,
You don't have ultrasound. You don't know that. So we would not do a change in protocol for that, just because you don't have the tools yet to figure that out.
yeah,
Does that kind of make sense? But it's interesting, and it kind of makes sense if you think about it, particularly with trauma, in terms of just doing more damage,
yeah,
when in fact what you really need to be doing is filling the tank.
yeah.
And as we get more experience with blood.
And then we get ultrasound to be able to
Yeah, absolutely.
properly diagnose
Yeah,
that.
right. Absolutely. As the way of backboards, cervical collars are falling more and more into disfavor. For many, many years, right? Everybody was on a backboard, right? We left on the backboard and they all got pressure sores. I mean,
Yeah,
it was terrible. Now the backboard obviously is a good tool for, extrication movement of patients, but we don't, even in the trauma room, there's a College of Surgeons criteria that patients must be cleared from the backboard within 15 minutes of arrival.
yeah,
So we get patients off boards. And now the question is, should all these awake and alert patients have cervical collars, or should the guy who falls in the nursing home, should he have a cervical collar on? And there's case reports after case reports of cervical collars not only inappropriately or improperly applied, but they all migrate up, right? You've all seen the old guy it's on his face, it's on top of his head, all these things, and they aspirate. There's all kinds of bad things that happen to patients that are in cervical collars. So the question is, should we even be using them? The answer
mhm,
is, well, we're not going to make a protocol change, but there's the nexus criteria, but how do you clear a cervical spine?
yeah,
The wake and alert, non-intoxicated patient, so I think we're going to probably spend some time really talking about that and a more appropriate choice about who we're going to put into collars. And so
yeah.
a lot of good research on that, that was kind of fun to hear.
How do you feel about using like the SAM splint? I've seen people use like towels and
Right.
blankets.
I think the concept is more spinal movement restriction. That's what you're really
Yeah,
trying to do. How you accomplish that in pillows, blankets, SAM splints,
yeah,
I think is easily as effective, and if not safer in some instances, than a hard cervical collar that puts the patient in an abnormal position. In a few years, we're probably going to look at that very carefully in the EMS
yeah,
systems. Is the cervical collar the right thing to do? And in an awake patient, anyhow, if they've got a neck injury, most patients with a neck injury, and they sort of splint anyhow. They're splinting themselves. They're not moving their head all over the place. I mean, they just don't do that.
yeah,
So, an unresponsive patient, probably not a bad idea to restrict spinal motion, in a cervical collar may be the best way, but there may be other ways that are better, and also
hmm,
give you access to be able to look at the neck, right? Be able to control the jaw, for
yeah,
jaw thrust. So the cervical collar, can, I can tell you, I've missed injuries, right? Missed subtle injuries, penetrating injuries to the neck when the patient's in a collar, because they don't
yeah,
take it off and inspect. And all of a sudden, you're an hour or two into the case, and somebody's got blood coming out from under the collar. And I said, what's that?
You're
Yeah.
like, where did that come
Oh, it's a
from?
hole.
Yeah. That's like people looking at the back. I've had some people tell me that they were like, oh, well, we never looked at the back. They get them to the ER and there was a bullet wound. And I'm like, oh, well,
Yeah, that's
yeah.
fairly common.
Yeah.
In the back, we had a patient who fell out of a tree stand recently. Brought in. Initially, actually, he had him on a backboard still, and I'm like, "Geez." We log rolled him off the backboard, and the guy says, "Man, my back really hurts." And well, it's because his, he still has his Glock in his,
Oh my
I'm like,
goodness.
guys, did you look at the back? Did you see the gun?
Be like, no, we did. You know how many times that's happened? Like, I
Well,
know people that
just
that
it
scenario
happens.
has
It
happened
happens.
to.
Guns keep coming up. Our last guest works for the coroner's office, and they have to put scenes together after traumatic things happen or homicides or whatever. They said, like, oh, like a lot of times we'll show up and we see a gun, we kind of just spaz out and like throw it. It's like, that's it. No, don't do that either.
Yeah.
Yeah.
Maybe just locate it and then safely put it away somewhere.
Right. No,
Yeah.
I mean, I think everyone needs to be trained how to properly handle a weapon and how to properly clear a weapon. Right. You need
Yeah.
to be trained on how to do that, or you need to know who's going to do that at the scene when you come up with a gun. Right. And many
Yeah.
patients are carrying guns, not for nefarious reasons. They just are. But you need to be able to safely take that weapon, make it so it's not going to hurt somebody.
Yeah.
Yeah. Just so you guys know, Taylor was not initially in this podcast and he just kind of walked in. But hi, Taylor.
Hi.
How are you?
I'm all right.
Yeah.
I'm gonna blame my lovely son. He does this like he's asleep, but he's still crying thing. I'm sure if you're a parent, you're probably familiar with this. Nonetheless, it keeps you up all night, and I needed some extra coffee. So thank
Yeah.
you for being patient.
Yeah. He left us for coffee.
Yeah.
And I will do it again.
Oh, well.
I love coffee. It is my
Uh,
favorite food group.
Was there anything else that you kind of learned from that conference that was super compelling or?
And a lot of mobile integrated health stuff.
Yeah.
With
Which I was going to say,
Keep going
Taylor
back to
right
this.
there.
Yeah, in terms of, just lots of things, everything from, the nurse triage calls to not dispatching a 911 unit at all to, evaluating the home for safety on the third time you've been called for a lift assist. What do you do?
That's encouraging to
Right,
hear.
right. And so, I mean, I think there's probably, and there's some money in it right now, right? There's some grant money in it. So some departments are able to do that. It's kind of hard because you can't really bill for those services. There's some conflict with home health agencies if you sort of overstep your bounds. But during COVID, as an example, we sent patients home when our hospitals were full.
Yeah.
We sent patients home on oxygen from the emergency department. Right?
MIH really popped off in 2020.
It did.
Yeah.
And so, we'd say, hey, go buy CVS and buy one of those there pulse oximeters. And we're going to have home health deliver oxygen to your house. And if it gets, about, below 85 or something, you might want to think about coming back. But, sometimes we send kids home as an example like that. And so in many communities, and we did this in Florida to some extent, we would call the EMS system and say, hey, can you guys go check on that kid, make sure the kid's okay? And so that was kind of the informal beginning of a lot of that concept of, mobile health, where you're kind of making house calls and checking on patients that have, that we're kind of worried about. There's now a lot of there's becoming more of this concept of hospital at home, where patients who otherwise meet serious criteria for hospitalization are being managed at home. And, how does the EMS system integrate into that? Because that's a very different kind of a patient. And,
it's it's an entirely different tab. Like it's, I don't know. It's the continuum of care. Like,
no, absolutely. Yeah, it absolutely is. And it's so, it initially started as like your frequent callers, right? How many times we've got people right here in Fort Wayne who've called 911, over 100 times, right? And I'm sure that folks listening to this know who those people are.
Yeah, we do MIH now. We might not even realize it.
Right.
You're signing off a diabetic. That is MIH.
Yes, it is. So, But is there a better way to manage a lot of 911 calls? And the answer is yes. But you have to have the finances to do it, right? Um, so I think there's going to be a lot of advances in mobile integrated health.
Yeah,
And
it's a
EMS is going to be
little
a big
above
part
its
of that.
time, I think. Company I used to work for before I started doing this, they made money because I had so many questions. Like, this doesn't make sense. Like, how are you making money? You're saving people money, but you're making money. It just didn't really make sense. They got their money through Medicare, Medicaid. They would basically
Right.
say, hey, Joe Bob cost you $800,000 of medical bills, the state. We'll manage his care and we'll cut it down to like 200,000, but we want 200,000 from you. And so they ultimately ended up saving a bunch of money and everybody kind of won. I don't think I'm kind of ignorant to how other companies are doing it, but
Yeah,
I think
that's
that's going
right.
to
The
be
ones that are the most successful are contracting with insurance companies, and particularly insurance companies that are Medicaid based. So the model you just described that's exactly it. Like you're gonna pay us, but we're gonna save you money because we're gonna keep this guy out of the ER. We're gonna keep him out. We're gonna take him to an alternative care site than the emergency department. We're gonna refill his prescriptions from his house, not an ER
yeah.
visit. I mean, stuff like that.
I
So
It was fun. I loved it. As
no,
a
I think
paramedic standpoint, it
right.
was so non-restrictive. Like you walk in, okay, hi Joe. Like it really seems like you're having a hard time managing your medications. Let's have a conversation about that with the doctor. Oh, it turns out you have transportation issues. Well, we didn't know that. We'll just get your med
Right.
sent to your house, nipped in the bud,
Yep,
done.
absolutely. Right.
Like
Right.
just so smart.
Yeah, and
Makes me really excited to hear you say
yeah,
that.
and COVID taught us a lot of that, right? The tele visits.
Yeah.
It used to be, oh my gosh, who would even think of that? Visiting the doctor basically on your phone, and it ends up being it's pretty successful actually. And there's very, very well, there's not a lot of case reports of any bad outcomes, honestly, and it ends up saving everybody a lot of time and a lot of money. So I think it's going to be kind of the next big area of expansion, and EMS has to clearly be involved in that, from the 911 dispatch decisions to what personnel do you actually send to the scene, and how do you do that, and the contracts with insurance companies, and so. But I think it's going to be sort of the next big expansion.
I know that there are some county departments. I know you said Adams started rolling one out, and I don't know if I'm not even going to say names because I don't know for sure, but I've heard rumblings of a few people doing it, and so I guess I'd be curious from your standpoint, like have you heard about some local areas doing it,
Well,
and if so, what's going well?
There's a City Block is a organization that's currently doing it. And there's some former medics, I think, they used to work within the system here in Fort Wayne that are part of that, right? And so City Block is we've been looking at whether to contract with them from a trials 911 point of view to actually you triage the calls to them and actually send them to the scene for those low acuity calls.
Have they started doing that?
Not yet, but we're very close to
I remember
doing that.
they started that conversation about a year when I was
Right.
working with them.
Right.
And the thing is too, like there was only 2 of us in Fort Wayne. So they only had 2 medics. And so how are they going to handle that logistically? But
Right.
I'm sure that conversation could be had.
Right. So, and some systems use nurse practitioners and PAs, which is even, they have an expanded scope. Obviously, they can do prescriptions at the scene and all kinds of stuff. So I think it's an exciting piece of EMS.
Absolutely. I think it will be where not that EMS, not that the emergency port like is going away. No, it's just reallocating things that are not emergencies. And then when you show up on that call and you're like, okay, clearly like this is not what we thought it was. Like you need to be in a hospital. You can do that. It's not like everything needs to be figured out at my age. No.
And the other thing you'd asked me about San Diego, a lot of discussion about lights and siren response. So it's high risk, right? You know that. Anytime you're taking heavy apparatus, whether it's fire, trawl, anybody through intersections and in the lights and siren. And so many EMS systems have reduced some of them, less than 50% of their calls now are dispatched. And And with trauma, I think it's about 53% are still now lights and siren, but we looked at a lot of protocols there and about doing non-lights and siren response. The frustration I understand from the fire department's point of view is that as a first responder, you're on the scene and you're sitting with a patient with a fall and a hip fracture, as an example, which would be non-lights and siren from a trauma point of view. And that next ambulance in may be 45 minutes, right? So it's very frustrating in systems that do this for the first responders because you're there. The patient, needs to go to the hospital. They're not emergent, but they need to go to the hospital. Broken hip is a perfect example of that. And you're just there. You're out of service. You're just waiting for a non-lights and siren ambulance to come to the scene when in fact you may have gone lights and siren yourself with that response.
Mm-hmm.
So in a first response system as we have here, we really need to look at, well, should both agencies really look very carefully at lights and siren response? And should we kind of mirror what we're doing in terms of lights and siren response? First and foremost for the safety, right? The safety of the crew and the safety of the public in terms of lights and siren response. And second, does it make any difference from a medical point of view anyhow? And it probably doesn't. I mean, if you just think about your own experience, right? Is how many times did an extra minute or two that you saved with lights and siren, did it really make a difference? Pretty darn rare. Pretty rare.
Yeah.
Versus how much you risked your crew in the public safety in that response. So there's quite a few systems that are looking very seriously at decreasing significantly their lights and siren response to EMS calls.
Yeah. Going back to why are we doing what we're doing? Is it just because it's always been that way? Or?
Right. So measuring response times as a part of performance of the system, is that really what we need to be measuring? Should we measure something else like patient outcomes? Should we measure something else like if you went non-lights and siren response, but in the lights and siren response to the hospital, did we get that wrong?
Mm-hmm.
And how can we correct that? So I'm not sure that response times is the way to measure a system, not in things that aren't time important. In fire suppression, I think it's a different story.
Absolutely.
Right? But EMS, I think not.
It's good to hear you say that.
Yeah.
Were there any presentations on pain control and like non-opiate analgesics that are, I guess, currents in the EMS world right now? Like our system, because that's such a hot topic right now.
Right.
And it has been for a long time. And like you said, like out of necessity, sometimes innovation is born, or innovative, creative solutions are made. And I know that there are some, but they're not widely used, like nitrous or even like Toradol in
Toradol
EMS.
Is a perfect example, right?
I guess, is that something that was talked about there, or what are your, if not, what's your opinion on some of that?
Yeah, my opinion is that part of what we're in this business is to alleviate suffering. So, while administration of a narcotic is not life-saving, perhaps, if that's your femur sticking out of the side of your thigh, I think you probably would want that. So, I think that we truly have that's part of what we need to do is to alleviate suffering. There's all kinds of DEA rules around this, in which it makes it very complicated, particularly for a non-transporting EMS agency. So it's very hard to get around the DEA. But there are, what we call multimodal approaches to pain management. Did you properly splint? Do you use ice? Tylenol and Motrin, pretty effective. That's what you do when you bang your shin at home. Toradol, I think, is really, I use Toradol a lot in the emergency department. It's a very effective medicine. Nitrous, the hardest part about nitrous is it's abused, right? Is to control it. It's just so easy to, let me see if there's any nitrous in this bottle. And, it's very hard for agencies to be able to control nitrous. Sub-anesthetic doses of ketamine, certainly for pain control for the serious trauma patients. And it may even be better than narcotics just because it doesn't affect the hemodynamics as much. So a lot of agencies are looking at ketamine as the first drug in for pain control for trauma patients over fentanyl.
Yeah.
Just because of it doesn't affect, you don't get hypotension from it or other, problems.
It works extremely well. In my limited experience, I was like, whoa, that was amazing.
In sub-anesthetic doses, the problem is these are small doses, but they are very effective. a lot of discussion about anything other than narcotics.
Yeah. We get hit up a lot about this topic, and I think it would be beneficial for you to maybe explain the DEA thing that you mentioned, like how that kind of complicates a lot. Like it's not simply just, oh, well, this would be ideal, so let's just do it. All right, next subject. Like it's quite a bit more complicated
It
than
is.
that.
Yeah, the DA, first of all, the DA never even considered EMS as, for the longest time, in terms of what you do with, controlled substances. And so, and they're still not, have not done a good job of writing rules and regs around that. Their interpretation, they gauge a lot of their rules and regs around transporting agencies. So transporting agencies, can now carry narcotics now under the agency DEA license. It used to have to be under my DEA. And in fact, in the early days, it had to be delivered to your DEA address, which could be your house. So, not like FedEx dropping off a bunch of fentanyl, I'd rather not have that.
Yeah.
No,
sounds
that's
like
bad.
a
That's
sticky
bad.
circumstance.
No, that's bad. So unfortunately, thank goodness that changed, where the agencies can have their own, but they have to be transporting agencies.
So you said for someone to have a license, they need to be a transporting agency. Is that particular to opiates? Is it certain schedules of controlled substances? Like, for example, would you need a license to carry nitrous or Toradol? Like, so those are the
Right.
first two
Probably
alternatives
no,
I can
yeah.
think of. Do
Yeah,
you need a license for those?
The DA only has control for the scheduled drugs, which would be your benzodiazepines and your opiates, primarily.
Okay.
Those would be the ones. So I know it's very frustrating, particularly from Fort Wayne Fire's point of view, when you have a lockbox sitting there in an ambulance that has the medications to alleviate suffering, and you don't, it's not a life threat. So in theory, you can't access that. You can access benzos for seizures and ketamine as well, for some things, but not the narcotics. I'm fully supportive of having access to everything that you have available to you.
Mhm.
But the rules are they're archaic.
Yeah.
They're archaic rules.
And it's not
And
like they're your rules, like they're the DEA's rules.
no, it's archaic. And so there's been a lot of pressure on the DEA to really, let's make some sensible rules here for many EMS agencies that are non-transport, but still have, their own license, which would probably be the best, that you have your own lock boxes. So you have access to the modalities that you need to alleviate suffering. And there's a lot of pressure from a lot of, significantly large EMS systems in the country pressuring the DEA that let's change this. Let's get this right. In the meantime, we're just kind of stuck on this.
Could we visit non-opiate, non-controlled substance, like carrying them, like nitrous or Toradol, or
We can
other things? Like,
yeah,
is that something that we could talk
we
about?
did, and it was so how medical direction in the public utility model, which is the EMS Foundation, is 4 physicians from Parkview, 4 physicians from Lutheran, and then they, at their whim, they appoint and hire a medical director. And in this particular instance is me. So, but the overall ordinance basically states that the EMS Foundation is the one that makes the final decisions for all protocol changes, et cetera. So that takes away some of my authority to do
Yeah.
that. Toradol, as an example, has been discussed, and while every physician in that room uses Toradol like water in their current practice, there's not a lot of literature out there yet that talks about Toradol in the pre-hospital setting. And so
I know they use it in MIH all the time.
Yeah, they do. But, and that's part of what we need, and we should probably participate in this as well, as an example, as a sidebar, which is, if we're doing something and we try something different, we probably should study it. And then we should, publish it.
And say, use that data.
This sounded like a good idea. We look at it for a year, double sequential external defibrillation. Okay, we need to look at that scientifically. When we do it, did it work? or didn't it not work?
Mhm.
Right? I mean, let's not be anecdotal about it. Let's be scientific about it. And the same with, things like, and so if more agencies, because I know they're carrying it, Toradol is out there, but there's not a lot in the literature.
Yeah.
So part of it is, trying to convince a group of, now you can imagine there's 8 physicians in this EMS foundation. Getting 8 doctors to agree on anything, like, where do you want to order food from tonight? Just, you come on. So, but if you present data, right, that's what you need. And the other big thing that at the EMS conference was we're not publishing enough. We're not doing enough research. And, we've got some good data. We really do. You got a very searchable medical record, right? You got a lot of radio button points, right? There are a lot of things you can pull out of that record. You can search a lot of stuff.
It just needs to be done. Right?
Yeah. So you need a data scientist. You need a data scientist in your organization to really look at that. What do you want to look at? Let's look at 3 years of, ventricular fibrillation. Let's look at that. And what was the outcome? And then let's look at putting in, sequential defibrillation, double external sequential. And did it work? Other systems said it worked. Does it work in Fort Wayne? Well, we should study that.
Mm-hmm. I know you can't speak for these individuals. How ready are they to be open to or to say yes to trials like that? Like, hey, let's try this thing for a year. Like, are there any examples of protocols we have now that started off like that? Or like, well, let's just give it a year. We'll see how it works. And then, oh my gosh, that was successful. Like, we're going to implement that permanently. Or that was not the way we wanted that to go. We are no longer going to continue doing that.
Right. Blood is a perfect example, I think. So the answer to that is yes, the group was very open to that. Mm-hmm. And the fact that we've got to go ahead with blood. And a lot of the discussion was, okay, look, you need to identify, do you have patients that would benefit from blood? And we were able to identify those patients retrospectively. And then we have to, every single case has to be reviewed. You have to look at it. Did you follow the protocol? Did the patient's vital signs meet criteria to get blood? Did you make good decisions on that? Were there any bad outcomes from any blood reactions? All those things. And we need to look at it. And they've asked basically that we look at it for a year. And if you, at the end of that year, you go, you know what, I don't think we really helped a lot of people. And because there's a significant cost in a blood program, significant. The coolers themselves are like $11,000 a piece. Just the coolers. I mean, this is no Yeti.
Move over,
this
Yeti.
Is serious. Yeah. This is way Yeti. So, and then each unit of blood is about $550, $600, and we don't have a way of recovering those costs. Mm. So, you use an ALS2 charge, but there's no blood charge yet. CMS doesn't have a charge for blood. So every time blood is given, it's going to cost the EMS system money. And would that money be better utilized with some other program? Well, we don't know yet. We need to study it. And so, yes, to answer the long answer to your question, so this group said, look, you got to look at this because there's only a finite amount of resources in terms of money. And if we're spending a lot of money on something that helps maybe one, right, it's a cost benefit thing. Is there something else that we could use that $50,000 or $100,000 that we're putting up front on this? Is there something else that would affect patients' lives more? Like maybe, antibiotics for septic shock, some other program that would, that we could divert this money to. So
that's so nice to hear you say too, because like I think people, not by fault of their own, but just they're not privy to accessing like your experience, and so there's this perception where it's like, oh well, we can't use fentanyl, and that's because like Dr. Scott said no, or like they think one person like said like, oh, well, that administration didn't like that for whatever reason. So they just can't do it. No, it's actually a whole group of people that need to basically pass that. And so this is not any one person's decision.
Yeah, it's a consensus decision made by, emergency physicians.
It's good for people to hear. I think it will give them perspective.
Right.
Yeah. I think we had a lot of great points on this podcast. Thank you, Dr. Scott.
You're welcome.
Yeah. Absolutely love having you on. We're going to end it here and get Dr. Scott a little breather here, but just remember, guys, leave it better than you found it.